oblique from the mid-clavicular line to the anterior axillary line so that the drug spreads both ways. Please look at my hands, so that it catches the anterior cutaneous branches as well as the lateral cutaneous branches. The biggest problem with the subcostal tap is that it is not catching the lateral cutaneous branches. That means from the mid-clavicular line till anterior axillary line consistently. So that is why the invention of EOI block by Hamilton and colleagues, Manicam, in 2018. And subsequently we have the TAPA, M-TAPA, costal margin blocks. There are so many things which I would not like to just bombard you with that information. No jelly. So this is how we are going to place our probe. Can I have the ultrasound screen, please? This side is medial, this side is lateral. Can you see the top surface of the rib? The muscle which you see is the external oblique. In between two ribs, you see the intercostals. So as a beginner, I can use the rib as a safety net. I can deposit on the top surface of that. As I become more and more expert, I realize that this is the plane of the drug deposition. So I can do an interfacial plane block between external oblique and the intercostals, or as a beginner between external oblique and the rib. Is that clear? Now coming on to the M-TAPA, so in the mid-clavicular line, I feel for the costal margin, and there has to be a steep angulation of the probe. Okay, left hand of the screen, my dear friends, is cranial. Okay, so what I see is the costal cartilage. What I see underneath is the internal oblique and the transversus and the external going. In the TAPA block, initially they said deposit drug here and between internal oblique and transverse abdominis. Over the period, they realized that Tolgor and colleagues that use a modified TAPA, that means in between the internal oblique and the transversus. This is the plane. Okay, so this is the M-TAPA. Again, this is supposed to catch hold of anterior cutaneous branches and the lateral cutaneous branches. If you look at my probe orient trajectory, you would realize it's steep, oblique, and directed towards the thoracic cavity, and my needle will come from this place. How difficult is to place the needle and get it between the internal oblique and the transverse abdominis. So that is why I do not do it personally. There are people, there are RCTs where they have shown their efficacy in lap choles, in subcostal incisions. If you wish to try, you are most welcome. I prefer EOI block. The reason being, it can be done in the post-op period also, because my dressings are all placed inferior to the costal margin, and I am doing it at this place. This is the costal margin. So that's the beauty of EOI block, my dear friends, and it's a volume block, 25 to 30 ml of the drug which is given. So this completes our discussion on the abdominal as well as thoracic blocks. Let's do quickly the upper limb. Manish, you would like to demonstrate upper limb?
Sir, I think aap hi
So, just to add, I totally agree with Dr. Devesh. EOI is a very, very good block, especially when you suddenly know that your lap has been converted to open for whatever reason, and that happens very frequently with the surgeon. So you don't disturb their real estate where the dressings and everything is done. So you just coolly bring your needle, give it, and trust me, the patient will be so thankful to you. Otherwise, you see the difference between the pain of an open chole where the EOI is not given and where the EOI is given. It's virtually an idiot tooth block. Very, very few complications until you really want to cause the complications. So I think it should be given and practiced. Right. Thank you.
Sir, can you please clarify one thing, that for these superficial blocks like the EOIU block or the TAP block, subcostal TAP and the rectus sheath block, do we need to follow the anticoagulation guidelines?
Okay, very nice. So we have good guidelines in 2022 by ESAC. ESAC is European Society of Anesthesia Intensive Care, as well as ESRA, the European Society of Regional Anesthesia, where they have categorized the blocks as superficial and deep, depending on if there is a vessel which is encountered, whether I will be able to compress it or not. Okay. So in upper limb, infraclavicular has been categorized as a deep block, thereby meaning what Dr. Manish is asking is, if you're having a patient on clopidogrel gel or warfarin, do not do an infraclavicular, whereas as an expert, I can do a supraclavicular or a costoclavicular. Is it okay? Okay, so I'll be scanning the classical bread and butter blocks, that is the brachial plexus above the clavicle. So I placed my probe in transverse oblique orientation, okay, just above the clavicle. This is a linear probe. Left hand of the screen, my dear friends, is medial. So what do I see? The subclavian artery just keep rattling out. So the entire plexus is seen like this. So can I see the shimmery pleura? Can I see the rib? Right now my subclavian artery is resting where? Pleura. Would you like to give the supraclavicular at this level? No. What do I need to do? Now it's sitting more on top of pleura, still on pleura. So I need to tilt my probe into the thorax in this case. Where am I sitting right now? On the rib. So if you look at it, this is the perpendicular orientation. I am sitting on pleura. I keep tilting towards the thorax, keep tilting towards the thorax till I am sitting on top surface. This is very important. Otherwise, my corner pocket injection, the corner pocket is the place between the subclavian artery and the first rib. The inferior cord is located like this, inferior trunk. Okay, not, sorry, cord is not there, it's trunks and the divisions which we are talking. So I can injure my pleura. Is it okay? So next is keep scanning upwards. As I keep scanning upwards, my dear friends, on the left hand of the side a muscle appears. What is that muscle? Anybody? Anterior scalene. This is middle scalene. As I keep going up, I have to identify the neural elements. Can you identify a bony shadow? What is this bony shadow? Of which vertebra? C7. Why do I call it? This is medial, this is lateral. So this is the posterior tubercle, anterior tubercle, I cannot see. So seventh cervical C7 is characterized by a prominent posterior tubercle and absent or rudimentary C7. I go, can you see the C7 diving towards his intervertebral foramen? As I keep going cranially, my dear friends, cranially, I would see C6 coming. Can you see the classical C6? The anterior tubercle, the posterior